Hello and welcome to the CDO Magazine series. I'm Jake Dreyer with High Labs, and we are partnering with CDO Magazine, MIT CDO IQ, and the International Society of Chief Data Officers in this series of interviews. I'm here with Roger Jansen, the Chief Innovation and Digital Health Officer at Michigan State University Healthcare. Roger, welcome.
Thanks for having me, Jake.
It sometimes feels like the U.S. healthcare system is this, I think about this, the Titanic, right? It's moving in a direction which we know isn't helpful, but turning it seems almost impossible. Yeah. What are the tools that we can do to start to turn ourselves away from the iceberg?
Well, it's going to take a lot of courage. Let's begin there, right? Because you're talking about upsetting the apple cart for a lot of people who have become really, 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 really wealthy off of American illness. And whether it's because we're eating a bunch of bad food that sits in our body and causes inflammation or causes neuropathies or demyelinating events, to healthcare executives and hospital CEOs who we have seen make what we would rarely see in publicly traded companies as not-for-profit hospital CEOs. They want to keep those positions protected. And if you look at what the AMA spent last year, they spent more than the energy and military industry on lobbying in DC combined. So they want to keep things the way they are. I think the power needs to reside with the self-insured employer and the consumer. And so if we're going to change healthcare, we need to start having HR departments who are typically the ones negotiating benefits or doing TPAs. We need to have them understand healthcare a lot better than they currently do. And we need companies out there who are creating alternatives to the existing commercial insurance process that we're all going through. We also need to recognize hospitals are a big part to blame. We often talk about the big pharma companies, or we talk about the insurance companies. But people have to remember the hospitals are the one who negotiate those prices and pass those on to their consumers. And so, we can take a look at Axios just released a study today that found that many of the cancer drugs that hospitals buy are marked up from what they pay by 650% to the insurance company. And so we're really in a spot where there's an incredible amount of blame to go around. And I think unfortunately, it's going to take some level of government intervention. And I'm not advocating that we say Medicare for all, but I think there needs at this level, and I know this is difficult to say, but I think there is enough corruption in the healthcare industry and enough people who have made it seem increasingly complex that we're all being played fools. A really easy example of that is since 1977, there's been about a 200% increase in the number of physicians in the United States. There's been almost a 5,000% increase in the number of administrators. We have made this system completely unwieldy. Those big shiny buildings that are going up that are hundreds of millions of dollars are not lowering your cost of care. They're not improving access, and they're not improving outcomes. And I think that what we're seeing is people have to spend those monies in the shell games of being a not-for-profit so that those revenues aren't so high and those profit margins aren't so high that people don't question their profitabilities.
Part of what you're talking about, I think, is there are a lot of forces at play which can stymie innovation and growth. And there's another part of innovation which people don't like to talk about, and that is failure. You try something new and it doesn't work. And that's necessary to innovation. However, when you're dealing with the lives of patients, the stakes for that can feel extremely high. So how do you balance that? How do you balance the need to make sure that you are trying new things, you're innovating, but you're also recognizing that you have patients and members that require good care and a good experience?
I don't think that they're synonymous with each other, right? I think there is a difference that we need to recognize in these things. So what I would suggest is we need to look around a continuum versus discrete variables. And what I mean by that is most of healthcare is treating things that every human's going to experience: a rash, a cold, a cough, a headache, right? And we often say, well, these are life or death situations, and we dramatize it and we justify it via that. Reality is most of healthcare isn't life or death. And we have to kind of get off that bandwagon that everybody's saving lives all the time. That's not really true. And I think we need to start being honest with ourselves. So what I think you need to recognize is the business model of healthcare doesn't promote innovation. And so if we don't change the business model, it's going to be tough to adopt practices that are driving innovation. Give you an easy example. If you have 1 million people in your area and you're a hospital in that area, you can pretty much predict what types of disease, injuries, illness, and aging you're going to have, because the human lifespan's actually really predictable in most cases, right? And if it's not, that's why we call it rare diseases, and those are the outliers, and we don't really need to look at them. But given that, you know what programs you need to set up. You need to know what orthopedic programs to set up, what aging programs to set up. Those are all cash makers. The government and the commercial insurers are billing certain codes. If you're going to innovate and you cannot get those insurers and those reimbursement groups, those payers, to actually reimburse for those new innovations, you will not adopt them. There will not be new innovations adopted simply because people will not be compensated for those things. I think instead what we should think about is, with all this innovation out there, what can it do to help us stop spending so much money? And so I'll give you an example: pharmacogenomics. Many of the drugs that we put in our body every day are ineffective, or they don't have the ideal level of efficacy that we would like them to have. Yet we still have insurers pay for them. We still have ourselves pay for them. If we were to use pharmacogenomics, in many cases, we could find the drug that's most specifically tailored to you. It's taken years and it's still extremely rare, but some insurance companies are starting to see that light and starting to pay for that. That's just good science and it's good innovation, but it's not normal practice. And so, again, I hate to say this, but unless there's a code for it, innovation is really difficult to get people to adopt. I mean, you can do things in your human resources department and you can do some cool things with IT here and there, but true innovation in healthcare means we need true innovation in the business model.
Part of what you're, I think, a backdrop to a lot of the innovation that you're talking about, pharmacogenomics being one example, is just the massive amounts of data, which are the backbone to understanding and driving some of this innovation. And so I'd love to hear from you, what is, I'd say, the interplay between tools such as AI and ML, which can be used to gain insight from data that might not have been possible 10 or even just 5 years ago?
Yeah, it's tremendous, right? I mean, I think when we look at it, I taught PhD stats for 4 years, and I'm looking at this, like a kid in a candy store with all this information that we have out there in this data. The problem is we don't have interoperability between EMRs across this country to share that data in many cases. We still don't have, if you live in Denver and you travel to New Jersey and you get sick, they may not have the ability to access your medical record. They can anywhere in Europe. They can't do it in the United States. So one of the things we have to look at with this data is, can we get to a level of interoperability amongst EMRs, even though places like Epic and Cerner and others aren't pushing for that? I don't see how you can really take great care of the United States population if they show up in one of your offices and that data is not there. That being said, there's a ton of data that we are accumulating right now. I think things like digital health apps, fitness trackers, things of that nature can begin to provide us what I call a rhythm from the noise. We've treated so much of this data as discrete variables versus actually seeing them as part of a bigger regression analysis, if you will, where we can begin to account for different levels of variance in someone's outcomes by putting these combinations together and seeing how they interact with one another. And so what I think the data analysis is going to allow us to do is to stop taking a look at, if you will, main or independent variable one effects to dependent variable one effects, but understanding the interaction effects amongst the number of variables that drive outcomes in a way that we hadn't predicted. So AI and machine learning for us, we're trying right now to work with companies who can help us take the information out of our patients and begin to make predictive health journeys and pathways around that. So, for example, somebody who shows this many steps with this diagnosis and this level of blood pressure, we know that, I'm making this up, 8% of them in the next 2 weeks are going to have some type of myocardial event, right? That we're going to have to take a look at and say, let's get you in. Not that we know anything is going to go wrong, but you're showing up on our, regression line as saying you're coming pretty close to saying this might be an event. So I think it's going to help us be better diagnosticians, better organizers of information. But more than that, it's going to become a predictive tool for us to help hopefully prevent illness and injury as we go forward.
Mm. So there's two threads of what you just shared that I want to explore. So I'll go with the first one, which is the interoperability. And when you're thinking about how the impact of that sharing of data can have, it can create all sorts of issues. With provider directories, it can make it so that patients don't actually know which providers to go to or where those providers are.
Yeah.
With value-based care, it can make it so that actually being able to coordinate care can be very difficult. So what are the ways that data can be used to address those issues? What are the tools that we have to solve things like provider directory data or value-based care, since we don't have right now the pipe infrastructure to make that patient chart accessible everywhere?
I mean, there's some companies that are emerging in this space that are starting to gain some traction to do some of this, right? Like there's Bamboo Health and there's Michigan Health Information Network. Most states have some type of clearinghouse for health data. So I think there's ways to begin to capture, accumulate, and organize that information. The question is how close is it to real time and usable? And I think a lot of times when you look at data, if you don't organize it well from the get-go, it's a lot of information, but there's a lot of junk under the hood. And sometimes it can work against us in terms of creating clarity as much as it can work for us. Mm-hmm. So I think that we need to recognize that we need to create some pretty interesting standards across how we accumulate, identify, code, list as variables what type of data we're utilizing. And we need to be able to call that up, right? And we need to be able to call that up in real time when we're looking at patients or when we're looking at a consumer's, next steps in this journey. What I don't think we're there with yet is truly understanding the power of data in medicine, because most medical interactions are based off of very long training in a isolated physician office with a quote unquote expert. That data is then coming from pharmaceutical companies, other, research universities, AMCs, but that data is unlikely to interact with other patient data in any meaningful way outside of that clinic wall. And I think what we're doing is we're not picking up on patterns and rhythms in most cases that we could usually bring together. There's some groups. I know that a gentleman who created Apple Health Records and created another company called Citizen, who just recently sold, and Neil Sethi was trying to organize that health information across the lifespan. And I think that's a beautiful and a wonderful idea, because understanding my health at 8 may actually give me insights to my health at 80. And yet we don't have that long-term longitudinal viewpoint of things. And we're still, if you went back in a time machine, going to a doctor's office is pretty darn similar to what it was when you were a kid. There might be some new fancy check-in thing, but it's pretty darn similar, everything thereafter.
Thank you, Roger, for joining me today. And for any of you that are listening, thank you for joining us. And please visit cdomagazine.tech for additional interviews. Roger, thank you again.
Have a great day. Thank you.
Bye.